Hello, ladies and gentlemen. Thank you for standing by, and welcome to Zai Lab's 2026 AACR Investor Call. At this time, all participants are in listen-only mode. Later, we will conduct a question-and-answer session, and instructions will follow at that time. As a reminder, today's call is being recorded. It is now my pleasure to turn the floor over to Dr. Rafael Amado, Zai Lab's President and Head of Global Research and Development. Please go ahead, sir.
Hi, everyone. Thank you so much for joining us today. I am Rafael Amado, Zai Lab's President and Head of Global R&D. Before we begin, we will be making forward-looking statements today, and I ask you to review slide 2 for further details. Moving to slide 3, I'm joined today by two outstanding clinical investigators. Dr. Luis Paz-Ares is a leader in lung cancer. He's chair of the Medical Oncology Department at the Hospital Universitario 12 de Octubre and head of the Lung Cancer Unit at National Oncology Research Center in Madrid. Dr. Rohit Thumalapalli is an assistant attending physician and gastrointestinal medical oncologist at Memorial Sloan Kettering Cancer Center. He specializes in GI and neuroendocrine cancers. And on the next slide, the disclosure information for both doctors. Moving to slide 5, here's our agenda. Dr. Paz-Ares will present first-time intracranial data with zoci in small cell lung cancer, followed by Dr. Thumalapalli in neuroendocrine carcinomas. Both posters will be presented tomorrow at AACR. I will conclude with an overview of zoci's clinical development plan and additional AACR highlights, followed by Q&A. And with that, I will pass the call to Dr. Paz-Ares.
Hello, this is Luis Paz-Ares. I'm a medical oncologist at the 12th of October Hospital in Madrid. And over the next few minutes, I'm going to report to you on the intracranial activity of zocilurtatug pelitecan in extensive stage small cell lung cancer with brain metastasis. Extensive stage small cell lung cancer is a high-grade, very aggressive carcinoma characterized by early metastatic spread and a very aggressive clinical behavior and therefore poor prognosis. One of the characteristics is the propensity to develop brain metastases, which are actually impacting in survival, but also in quality of life. Some 20% of the patients really present brain metastases at the initial diagnosis, and over the time of the disease, of the natural history of the disease, some 70% of the patients do develop brain metastases. And as I said, that is really a very relevant clinical condition. And so far, the treatments are not the most effective for that particular issue. At present, when a patient is having symptomatic brain metastasis, we typically deliver radiotherapy, stereotactic or whole brain irradiation. And the problem is that often you have to stop systemic therapy while you're giving the brain metastasis irradiation to put the patient at risk of rapid extracranial progression. For asymptomatic patients, often we administer brain irradiation as well, and the risk being as well to develop into the future some cognitive deterioration. Overall, the survival impact is very clear for those patients. The real-world data suggests that typically the median OS for those patients is in the range of 8 months, being particularly bad for patients that really present brain metastasis are treated with whole brain irradiation. The rationale to use the zoci ADC into the brain is because it allows a target delivery of the payload on those tumor cells that are expressing DLL3, which is most of the cells. The payload is actually producing direct cytotoxic killing, and the good thing is that each ADC will have a good number of payload molecules of the topo-1 inhibitor. Is actually having a DAR of 8, and it's having a strong metastatic effect that really enhances the activity in the brain tissues. In the next few minutes, I'm going to provide you the data that are being presented at the AACR meeting this year. Pretty sure that you're aware of the background, what is social pelitecan, which is an ADC directed to DLL3 with a very efficient payload, a topo-1 inhibitor with a DAR of 8. It has a very relevant bystander killing mediated by the payload, as I mentioned, as the drug is typically released and accumulated into the tumor microenvironment thanks to the platform, the Tumuline platform that is being used to produce this ADC. The data from this study on brain metastasis are coming from the dose escalation and expansion phase 1 study ZL1310 using the ADC as monotherapy or in combination with atezo or atezo plus carboplatin in extensive stage small cell lung cancer with the data cutoff of February 2026 and a median follow-up of some 8 months. The intracranial activity has been actually assessed with an independent radiology committee using the mRANO brain metastasis, and with this criteria you may measure up to 5 brain lesions, and they should have been studied using the contrast enhancing, and importantly the diameter should be at least in the longest 10 millimeters and at least 5 in the perpendicular diameter. Included patients in these trials were patients with extensive stage small cell lung cancer, with asymptomatic brain metastasis, and archival biopsy was collected to retrospective DLL3 testing, good PS, and importantly, prior DLL3 directed therapy was allowed. You see here on part 1 and part 2 what was the dosing use, and from 0.8 milligrams per kg to 2.8 milligrams per kg in the part A1, and the part 2, the patients were randomized to receive 1.2 or 1.6 milligrams per kg. As you see here, some 136 patients were included on this study, and importantly, brain metastases were seen in some 36%, and out of those, about 1/3, 13.2% overall, didn't receive prior irradiation. So that means 2/3 received prior irradiation and 1/3 didn't before entering the study. As you see, 2/3 of the patients had received 1 prior line of therapy, and 1/3 had received 2 or more lines of systemic treatment, and more than 90% received PD-L1 therapy, and about some 10% of the patients received DLL3 T-cell engagers. The overall response rate that we have seen was 34%. 22 out of 41 patients responded, and responses were particularly high on those patients treated at 1.6 milligram per kg. That were 62% responses. 50% were assessed responses in cases treated with 1.2 milligrams per kg. Importantly, responses were seen in 50% of the patients treated with prior radiotherapy, and in 60% of those that didn't receive radiotherapy before entering the study. Out of the 22 responders, 21 responses were already seen at the time of the first tumor assessment. That means some 6 weeks. The other issue important is that 14 responders, that means 2/3 of the responses, are still ongoing with a median time of 9 months. You see here 2 illustrative cases. The first case on the top is a 60-year-old female treated with carboetoposide durva plus tarlatamab that developed brain metastasis, as you see here, during the induction treatment in the first line. Patient received without prior radiation ZL-1310 at 1.6 milligrams per kg, and as you see here, at the time of the initial evaluation, the patient was on complete response and still on complete response 6 months later. The second case was another female, 65 years old, that progressed while on initial therapy with carboetoposide addition, developing multiple brain metastases. Importantly, the patient didn't receive, before entering into the ADC study, radiotherapy, and as you see here, a clear response was already seen at the time of the week 6, that was evolving over time to and a scar remaining at week 24. Safety-wise, the drugs was reasonably well tolerated, and the typical side effects we have seen related to the drugs were typically seen consistent with the topo 1 inhibition mechanisms of the drug. You see here some about 1/3 of the patients at all those levels had some grade 3 or 4 treatment emergent side effects, but you restrict to those related to the treatment. You see that the doses that 1.2 and 1.6, only about 16 or 2% of the patients really had treatment emergent adverse events related to the drug. Typical side effects, particularly as you see here, are mainly myelosuppression. Others include, of course, nausea, fatigue, asthenia, and so on, typically only grade 1 or 2. So as a conclusion, let me tell you, the drugs ZL-1310 have demonstrated a quite relevant high intracranial response rate in patients with extensive stage small cell lung cancer with brain metastasis at baseline. As you remember, the overall response rate was in the range of 54%, including complete responses in 17% of the cases. Responses were observed in patients without prior radiation, 60%, but also on those with prior radiation, 50%. And the higher response rate was observed at the 1.6 milligrams per kg dose level. At this dose, the treatment was pretty well tolerated. Remember, side effects grade 3 or more were in the range of 15%, and we didn't identify new signals of safety, including no hemorrhages at the intracranial level. So this study is still ongoing. enrolling now patients that have received DLL3 targeted therapy before study entry. And in addition, there is an ongoing phase 3 study, the Elevate study in second-plus lines of extensive-stage small cell lung cancer, where patients that have progressed to platinum-based chemo with or without tarlatamab are to be randomized to SOCI versus the investigator choice of therapy, topotecan, Lourdes, or Amrogesen. So this is very much what I have to say today. So thank you very much for your attention.
So thank you, Dr. Paz Ares. I'm excited to be here to present the updated data for ZL-1310, or ZOSI, in extrapulmonary neuroendocrine carcinomas and other DLL3 expressing tumors. So extrapulmonary NECs are highly aggressive malignancies with very poor outcomes. 5-year survival in patients with metastatic disease is less than 15%, and median overall survival in these patients is only 5 to 8 months. Extrapulmonary NECs share key biological features of small cell lung cancer, including frequent expression of DLL3. However, treatment options remain very limited, particularly after progression on platinum-based chemotherapy. So while initial responses following frontline etoposide and platinum-based chemotherapy can be observed, durability is limited compared to small cell lung cancer. And most notably, in the second-line setting, there is no established standard of care. Physicians can use different single-agent or combination chemotherapies with response rates of around 20%, but short median progression-free survival. In addition, different from small cell lung cancer, there is no established role for DLL3 targeted T-cell engagers in extrapulmonary NECs, and no established role for immune checkpoint inhibitors. And so hence, there really is an urgent medical need for more treatment options for these rare and aggressive cancers. So this is a global phase 1b, phase 2 study of ZOSI in patients with extrapulmonary NECs and other DLL3 expressing solid tumors who have progressed on or after platinum-based chemotherapy. The study included 2 cohorts, one in gastroenteropancreatic or GEP NECs, and the other in other extrapulmonary NECs, including large cell neuroendocrine carcinoma of the lung, genitourinary or gynecologic NECs, Merkel cell carcinoma, and other DLL3 expressing solid tumors. For extrapulmonary NEC patients, DLL3 expression was evaluated retrospectively by immunohistochemistry, but was not required for eligibility. Initial cohorts of 10 patients were enrolled, with expansion triggered by observed responses, and the phase 2 part is a single-arm study, which is currently enrolling. The study enrolled evenly in the U.S. and China. As you can see, the majority of patients had advanced stage disease at enrollment. These tumors were highly proliferative, as reflected by the majority of patients having high Ki-67 levels. At baseline, nearly all patients had received prior platinum-based chemotherapy. About a quarter of patients had prior immunotherapy, of course, although the role for checkpoint inhibitors in extrapulmonary NECs is still debated. 5 patients received prior irinotecan. These were all in cohort 1, consistent with the common practice of using FOLFIRI or FOLFIRINOX in GI neuroendocrine cancers in the second line. So overall, we feel the study population represents a typical extrapulmonary NEC population that we see in clinic. In terms of efficacy, we saw encouraging antitumor activity with ZOSI. Among response-evaluable patients, the overall response rate to date is 38%, with a disease control rate of approximately 56%. We feel these responses are clinically meaningful in these aggressive tumor types with few treatment options after platinum-based chemotherapy. Tumor reductions were observed across multiple extrapulmonary NEC subtypes. The response rate in cohort 1, enrolling gastroenteropancreatic or GEP NECs, was 33%, and in cohort 2, which enrolled extrapulmonary NECs other than GEP primaries, the response rate was 44%. As shown in the waterfall plot, we saw substantial target tumor shrinkage in patients both in cohort 1 and cohort 2, although we did observe more patients in cohort 1 with primary progression. When we break down the data in more detail, we see responses were observed across the spectrum of extrapulmonary NECs. Interestingly, in the 5 patients who received prior irinotecan, which is another topo-1 inhibitor, no patient showed a response. All these 5 patients had gastroenteropancreatic NECs or GEP NECs. whereas a patient with NEC of the cervix who received prior topotecan, which is another topo-1 inhibitor, did achieve a partial response with ZOSI. More data is being generated to understand factors that impact response to ZOSI. We are also seeing early signs of durability with multiple cases of durable responses across different origins of NEC. These data are still immature, but taken together, these data suggest clinically meaningful efficacy with ZOSI. Similar to what we saw in small cell lung cancer, we have not yet observed a clear relationship between DLL3 expression and response. Importantly, responses have been observed in DLL3 negative patients, and we have seen activity across a broad range of DLL3 expression levels. While preliminary, this data does not support excluding patients from ZOSI treatment in the case of negative DLL3 expression. So taking a look at safety and tolerability, overall ZOSI demonstrated good safety and tolerability in extrapulmonary NEC, consistent with the safety profile of small cell lung cancer. Most events were low grade. The most common events were hematologic and gastrointestinal, including anemia, leukopenia, and nausea. There was only one case of grade 2 ILD among these 46 patients treated to date. We have limited data so far, but the ILD rate in patients with extrapulmonary NEC seems to be lower than in small cell lung cancer, and this may be related to difference in tumor burden in the lung and lower frequency of prior radiation to the chest. So in summary, we believe ZL-1310 or ZOSI is well tolerated compared to other treatment options in extrapulmonary NECs. To bring this to life, I'll walk through a representative patient case. This is a 52-year-old patient with small cell neuroendocrine carcinoma of unknown origin. He exhibited primary progression on first-line platinum-based chemotherapy and then initiated ZL-1310 and achieved a partial response within 6 weeks. We saw a large tumor reduction at week 6 with one of the target lesions nearly disappearing. The tumor shrinkage deepened nearly 75% by week 18, and the patient is still benefiting at time of data cutoff with a very encouraging durability of response of more than 6 months. In summary, ZOSI is demonstrating clinically meaningful activity in a very difficult to treat population. We're seeing responses across multiple extrapulmonary NEC tumor types and primary origins. And while cross-trial comparisons must be interpreted with caution, these response rates to date appear favorable relative to historical chemotherapy outcomes. The safety profile is consistent with what we observed in small cell lung cancer, and the study is ongoing with expansion into phase 2 and continued follow-up in the phase 1b ongoing to better characterize efficacy. And with that, I'll turn it back to Rafael.
Thank you, Dr. Sumalapalli. This next slide outlines our broad and comprehensive development strategy for ZOSI across both small cell lung cancer and extrapulmonary neuroendocrine carcinomas. Starting with small cell lung cancer, we are advancing across multiple lines of therapy. In the second line and third line setting, our global phase 3 DELEVATE study is ongoing. We expect to complete enrollment in the first half of 2027, followed by an interim analysis positioning ZOSI monotherapy for potential accelerated approval in 2028. At the same time, we are expanding into first line. Here we have multiple ongoing combination strategies. First, we're evaluating ZOSI in combination with a PD-L1 inhibitor plus or minus chemotherapy. We expect to present combination data, including first-line data, in a conference later this year and expect to initiate a pivotal trial by end of the year with the selected combination. Additionally, we also recently announced a collaboration with Amgen as well as Boehringer Ingelheim, which I will discuss in an upcoming slide. Turning to EP-NEC, we are advancing ZOSI monotherapy in the second-line setting, where there is significant unmet need. The ongoing study is generating registration-enabling data. In parallel, we're exploring combination strategies, including obrixtamig, through our collaboration with Boehringer Ingelheim to further expand the opportunity in this population. Overall, this strategy reflects our goal to position ZOSI as a backbone therapy across both small cell lung cancer and EP-NEC, spanning monotherapy and combination approaches and across multiple lines of therapy. I wanted to briefly touch on the recently announced collaboration with Amgen and BI to pursue combination strategies in small cell lung cancer and neuroendocrine carcinomas. The rationale is grounded in complementary mechanisms. ZOSI delivers rapid cytotoxic tumor debulking while T-cell engagers activate immune-mediated killing to drive durability. Together, this approach has the potential to both deepen and extend responses. Importantly, these agents are expected to have minimal overlapping toxicities. Combined with ZOSI's favorable safety profile and compelling systemic and intracranial activity, we believe it is well positioned as a backbone for combination therapy. We've initiated a global phase 1b study with Amgen evaluating ZOSI in combination with tarlatamab. The study includes dose exploration and dose expansion in both tarlatamab-naive and tarlatamab-exposed patients. We plan to also evaluate a triplet in the first-line setting. We also plan to initiate a global phase 1b/2 study with PI evaluating ZOSI in combination with obexelimab in neuroendocrine carcinomas, as well as a triplet combination with atezolizumab in first-line small cell lung cancer, and depending on emerging data in first-line EP-NEC as well. Amgen and BI will sponsor and lead their respective global studies. Overall, we see ZOSI emerging as a differentiated DLL3 ADC with the potential to become a new standard of care across small cell lung cancer and extrapulmonary neuroendocrine carcinomas as monotherapy in previously treated population and as a backbone in the frontline combinations. With that, let me turn to the broader pipeline we're advancing at AACR. ZL-1222 is our IL-12 PD-1 immunocytokine. It is designed to overcome the key limitations of current immune checkpoint blockade, which has had limited activity in cold tumors, and systemic IL-12, which could result in significant toxicity. It combines PD-1 targeting for tumor localization, it silences FC for half-life extension, and a potency-reduced IL-12 to improve tolerability. This enables localized activation of IL-12 signaling in the tumor microenvironment, reprogramming the TME and activating T cells to drive durable anti-tumor immunity. We see clear anti-tumor activity. ZL-1222 inhibits tumor growth in the ICV-resistant model, EMT6 with good tolerability, and shows dose-dependent efficacy that tracks closely with exposure in CT26 model. Together, these data show that ZL-1222 can drive meaningful anti-tumor responses in a biologically predictive profile. Our pilot toxicology study in non-human primates showed tolerability up to 10 milligrams per kilogram. We are currently conducting a dose range finding study and are preparing GLP toxicology study to establish its safety profile. We're now advancing towards IND-enabling studies in 2026. Turning now to ZL-6201, our LRRC15 targeting ADC. ZL-6201 combines a humanized anti-LRRC15 antibody with a protease-cleavable linker and a camptothecin-based topo-1 payload. Mechanistically, this enables efficient internalization and payload release in targeted cells, leading to DNA damage and tumor cell death. Importantly, LRRC15 is broadly expressed across sarcomas and in cancer-associated fibroblasts within the stroma of many epithelial solid tumors with limited expression in normal tissues, making it a highly attractive ADC target. Collectively, these findings highlight the potential for ZL-6201 to address significant unmet need across both mesenchymal and epithelial malignancies. Looking at the efficacy data, ZL-6201 demonstrated dose-dependent tumor growth inhibition across multiple LRRC15-positive sarcoma patient-derived xenograft models. We also observed robust anti-tumor activity in non-sarcoma CDX models where LRRC15 is expressed on cancer-associated fibroblasts rather than in tumor cells. In these models, CAFs facilitate the release of C24 payload to deplete neighboring antigen-negative tumor cells, demonstrating potent efficacy driven by a strong bystander effect. Together, these data support the dual mechanism of action involving both direct tumor cell killing and stromal targeting. Based on this profile, a global phase 1 study is now underway with enrollment acceleration planned in 2026. And with this, I will end the highlights from AACR. Now, please join me, Dr. Pazares and Dr. Thumalapalli, for questions and answers.
Thank you. We will now begin the question and answer session. To ask a question, please press *1 and 1 on your telephone and wait for your name to be announced. To withdraw your question, please press *1 and 1 again. Please stand by while we compile the Q&A roster. We will now take our first question from the line of Jonathan Chang from Leerink Partners. Please ask your question, Jonathan. Your line is open.
Hi, guys. Thanks for taking the question. Dr. Arias, how should we be thinking about the intracranial activity of ZOSI relative to standard of care and development stage treatment options in small cell lung cancer? And how should we be thinking about the impact of this intracranial activity on overall survival? Thank you.
Well, of course, those are, today is still early days because we haven't got, let's say, very robust data in terms of phase 3 trials. The only thing I can tell you is that the response rate we have seen, do you remember 54% overall intracranial response rate being 62% on those patients that actually were treated at a 1.6 milligrams dose. I think this is quite impressive in this setting as compared to standard of care drugs, which are more on the 20 to 30%. That is at least encouraging data, thinking into the future about the possibility of impacting survival. At the same time, you're able to really get responses in the brain. Very likely, I would assume that you have good possibilities of getting better or improvement in quality of life. Having brain metastasis, particularly symptomatic brain metastasis, are really impacting very much on what you're able to do and your quality of life. So I would say the early data are really encouraging, but still, of course, is going to be needed randomized phase 3 trial. I'm pretty sure the trial we just described in the pre-treated setting is going to give us a more robust data, but early data are very encouraging.
Understood. Thank you.
Thank you. We will now take our next question from Michael E. from UBS. Please ask your question, Michael. Your line is open.
Thank you. Good morning. We had 2 questions. One was just thinking about the enthusiasm about this data in intracranial tumors and how that would drive a robust response in the phase 3 frontline small cell study, where obviously it's much better to treat earlier. So could you talk a little bit about what type of results you would expect to then see in the first-line study and how that would compare versus, say, tarlatamab, which has a first-line label? And the second question then is, I guess, you're going to combine the two, so how would that be envisioned if the two of them are combined? Thank you.
Okay, so related to the first question, I could say, typically our diagnosis about 20% of the patients are having brain metastasis, but it's not only important to treat those 20% of the patients, but also to prevent brain metastasis to happen in the future. That is a very frequent site of disease progression. So having a drug which is very effective into the brain likely is going to prevent brain metastasis to happen, or at least delay that progression to happen. Of course, tarlatamab is an amazing therapy with clear impact on survival and in other endpoints. The ideal here would be to be able to combine those drugs. I think, this is My anticipation would be that, there are a couple of trials in the first-line setting, induction and maintenance. I would assume in the near future, the result of those trials are going to be positive, and tarlatamab is likely to be part of the standard of care. So the way I envision this ADC against DLL3 in the first-line setting will be in combination with tarlatamab, and hopefully that could have at least, there are good rationale to really have a synergistic effect between both of them. And I think, it's been commended by Rafael that combination data are going to be produced, and I suppose frontline would be a quite urgent strategy into the future.
Thank you.
Thank you. We will now take our question from the line of Anupam Rama from JP Morgan. Please ask your question. Anupam, your line is open.
Hey guys, thanks for taking the question and congrats on the update. One for the company. So in the phase 3 Delevate study in second-line plus small cell lung cancer, can you walk us through the rationale to stratify based on having brain mets or not? Isn't the activity that you're seeing today here at AACR ultimately within brain mets that's going to be key for PFS, right, in the overall population as de-risking? Thanks so much.
Yeah, that's a very good question. Thanks for asking. Generally, these studies are stratified by brain metastasis because they pertain a poor prognosis, as was remarked upon at the beginning by Dr. Paz-Ares. The difference in second line of survival may be between 5 months to 9 months for those that don't and those that do have brain metastasis. So stratification ensures that the number of patients with brain metastasis is equal in both arms. Now, the point that you're making, I think, is that if brain metastasis patients appear to do equally well as those that don't when they're treated with zoci, why stratify? In the control arm, that will not be the case, and we wouldn't want to be an unevenness in the control arm whereby what preponderance of patients with or without brain metastasis occurs, and then the comparison wouldn't be apple-to-apple comparison. So I think in spite of the good data that you've heard today, because it's a randomized trial against chemotherapy, the stratification is necessary.
Thank you. Do you have any follow-up question, Anupam?
No, thanks for taking our question.
Thank you very much. Our next question comes from the line of Igor Notromovic from Citigroup. Please ask your question. Igor, your line is now open.
Okay, thanks. I thought I heard my name. So one for Dr. Paz-Ares, one for Dr. Thummalapalli, and one for Rafael. So Dr. Paz-Ares, I'm wondering, with the 10 patients that had responses intracranial, could you describe whether they also responded systemically? What was the concordance? As I recall, with tarlatamab in their intracranial data, I believe the concordance was quite high.
Okay, so again, here the concordance is pretty high. Those data have been already reported I think in prior trials, and the response rate is over 50% as well. So the important thing would be because there are a number of drugs that induce a reasonable response rate systemically, but they fail to produce the same type of activity in the brain. And the reason for this presentation here at the AACR is specifically to highlight that the responses you're seeing in the brain are similar. So there is no problem to access into the brain and to induce responses here. That is very much the reason.
Okay, thanks. And for Dr. Similopoulos, I'm just curious, do you have any theories as to why you're not seeing a differential response with respect to DLL3 expression?
Yeah, yeah, it's a great question. I mean, I think, we've limited data so far. I think there could be a number of reasons. In extrapulmonary NECs, DLL3 expression is not as universal as it is, or at least as prevalent as in small cell lung cancer. There also could be some heterogeneity. There also could be other factors that are DLL3 independent that could be associated. Of course, the drug also kind of invokes a bystander effect as well, and so you may not necessarily need kind of high-level homogeneous DLL3 expression. You could potentially respond to the drug even with lower levels. So I think a lot of different possible reasons, but I think that the data will bear out with time.
Okay, and for Rafael, quickly, you have the interim coming up next year, as you mentioned. What more can you tell us today about that interim? The sorts of questions we'd want to know would be the percent of PFS maturity, what you can say about the bar, meaning the critical hazard ratio. How much can you tell us today about what would be necessary for that study to report a positive interim next year? Thank you.
Yeah, the critical endpoint for conditional approval or accelerated approval is response. It's not PFS. And FDA will be looking at duration of response, and the analysis will be done when patients have been able to or have had an opportunity to be followed for at least 6 months after the first scan. And the agency will be looking at the durability of that response as well. So it won't be based on PFS or survival, but rather on differential response rate and the durability of that response. And in terms of the type of difference that needs to be seen, this is not something that we've commented in the past, and I think it will be probably something that FDA will deem clinically relevant. And I can tell you that we are tracking very well for that endpoint. We plan to have accrual by the end of the next quarter, and shortly after we will be able to do the analysis. So fingers crossed, and stay tuned.
Okay, thank you.
Thank you. We will now take our next question from Lee Wasik from Cantor. Please ask your question. Lee, your line is open.
Good morning. This is Mubin on for Lee. Question about the next JOSI update. So it seems like the next update is going to be in the second half of 26, and that's going to be the combination of chemo and PD-L1. Can you guys set the expectation there? What kind of data we should expect to see? Thank you.
I think you're asking about the frontline data with chemotherapy and PD-1. We treat a number of patients with both PD-1 in second line as well as in first line, and then in first line with carboplatin as well. All that data is maturing. The majority of patients are with PD-1. I can tell you that the toxicity does not seem to be overlapping, and we've been able to advance the doses as expected. We obviously are observing data that is very encouraging to us, but we need more time to see what the durability of that data is going to be. Our hope is that with good data sparing chemotherapy, we would be able to treat longer than with chemotherapy alone. The majority of patients with chemotherapy alone, tend to stop after about 4 cycles or so. And given the tolerability that you've seen with Zosi and the one that we're seeing with Zosi plus PD-1, that the treatment to progression or toxicity would be longer with Zosi. So I think that is the underpinning of that phase 3 study We're in discussions with regulators at the moment as to the actual details of the design. But as said in the prior remarks, we plan to present the data in the second half of this year, sometime in one of the meetings in the fall.
That sounds good. Thank you.
Thank you. As a reminder, before we take our next, it is star 11 on your telephone keypad if you wish to ask a question. We will now take our next question from Linhai Zhao of Goldman Sachs. Please ask your question, Linhai. Your line is open.
Thanks for taking my question. This is Linhai. Very exciting results. Congrats. I have two questions. The first question is, how do you think about the potential confounding effect from the prolonged intracranial efficacy from the previous radiotherapy? What is the time gap between the last radiotherapy to the first dose of Zoci? That's the first question. And the second question, I would appreciate some clarification as I see in the page 9 of the deck. It was showing that Zoci was able to penetrate the blood-brain barrier and enter within the brain tissue. That was somehow the reason that it can generate the high intracranial efficacy. Just want to clarify if is my understanding correct? Thank you.
So maybe
I was just going to say that the protocol requires at least a 7-day washout for radiotherapy, but Dr. Paz-Ares, please go on.
No, yeah. So, I mean, for sure, a washout was required. So the only thing I can say with this limited data is that among those patients that didn't receive radiotherapy before, the response rate was 60%. Now, 9 out of 15 patients, and it was very similar, I would say 50% response rate in patients that have been treated with prior radiotherapy, 13 out of 26. Then, the number of patients are too small to really, dissect on the time elapsing since last radiotherapy, always knowing, as Rafael mentioned, that anyway, it's going to be at least two weeks from last radiotherapy dose. So and you need to have a control image before starting, baseline post-radiotherapy. So that means the effect you're observing is not due to the radiotherapy, but is due to the drug. But anyway, I mean, that is the maximum we can say about those data, I have to say.
Follow-up question, Linhai?
Yeah, just on the second question is the ability of Zoci to enter to penetrate the blood-brain barrier.
So I mean, let's say the idea here being that the way the drug is working, is brain metastasis, of course, because our small cell lung cancer express quite uniformly DLL3 in the surface of the cell, and that facilitates the entrance into the tumor and into the microenvironment. The drug is actually delivered with a high number of molecules of the payload per cell. Of course, we know that when brain metastases are there is a disruption of the brain barrier, and actually the fact that we have observed such a high response rate somehow validate that concept, I would say. I don't know, Rafael, would you like to add on something based on the preclinical data?
No, nothing else. I think the disruption of the blood-brain barrier is an excellent point. And also, this is a very avid antibody with very, very low nanomolar affinity. So binding to DLO3 is with very high affinity. So perhaps that is one differentiating factor that makes it possible to have such high activity.
Yeah, that's very helpful. Thank you.
Thank you. Once again, if you wish to ask a question, please press star 11 on your telephone keypad now. Showing no further questions, thank you all very much for your questions. I'll now like to turn the conference back to Dr. Rafael Amado for his closing comments.
Thank you so much, Dr. Tumalapalli and Dr. Pazares. We believe that the data presented today reinforces the potential of ZOSI as a differentiating agent in DLL3 positive tumors and supports our strategy to advance it into multiple lines of therapies and in combination settings for both small cell lung cancer as well as neuroendocrine carcinomas. So we are executing against the comprehensive global development plan as I outlined, including the current ongoing phase 3 study. And we look forward to sharing additional data with you as the program progresses. We appreciate your time and interest today, and we look forward to keeping you updated. Thank you so much. Have a great day, and operator, you may now disconnect.
Thank you for your participation in today's conference.